coordinator here at St. Jude, putting on this show today, and I've got my lovely colleagues, and without further ado, I'm going to go ahead and turn it over to them.
Yes. Good morning, my beautiful people. Buenos dias. I hope everyone is having a beautiful and blessed morning. Once again, we apologize for the minor technical difficulties, but without further ado, I'm going to go ahead and introduce myself and my amazing colleague. For those of you guys who don't know me, my name is Jessie Claudio. I use he, him pronouns. I'm based here in Memphis, Tennessee, and I work for the Latinos, the Latino Commission on AIDS. Exactly, that's where I work. And my title is Community Building Manager. And I'm gonna go ahead and introduce my coworker, Judith.
Hi, good morning, everyone. There we go. Good morning, everyone. I'm Judith Montenegro. I am the Program Director of Latinos in the South, which is a program of the Latino Commission on AIDS. And today, we're going to talk about protecting access and the impact a lot of the policies that are happening are impacting Latinx and immigrant communities, especially folks who are needing HIV prevention and care, right? And okay, a little bit about the commission. We were founded in 1990, and we were really founded to address the HIV epidemic at the time impacting Latinx communities. And so we work alongside community-based organizations, AIDS service organizations, health departments, and faith-based institutions to ensure that they're really serving Latinx communities. And we also work across different health challenges aside from HIV, including STIs and viral hepatitis. And our program, Latinos in the South, is a regional program that is based in 9 states. We work from North Carolina to Texas. And the commission, a couple years back, our program started in 2017 or 2011. Anyway, our program started, and now we have many more colleagues in the Southeast. So of our 47 staff members, 17 are in the South, doing remote and hybrid work in North Carolina, Florida, Georgia, Texas, and Tennessee.
All right, current landscapes. So I am curious to hear from you guys, both our audience and those joining us online. What changes has your organization made because of the administration changes? And how are you mitigating these losses, and what are the opportunities? So as we know, there's been a lot going on in our government. A lot of executive orders. So we just wanted to hear what have been some of the things that have been going on in your organization. So if anyone would like to kind of share or give us a little bit of insight. Yes, I see my colleague Krista back there. Thank you so much for that.
So for those of you all who may have not heard, yes, we did have someone speaking, and they were sharing that as someone who works in the health department, they can't share too many details, but that changes have occurred, including staff changes and how they're resourcing some of these funds internally. And so the important message here is that they're still here to serve. And we really wanted to create this space because often we don't have a space to really talk about these things, right? About what is actually happening in some of our organizations. And 2 days ago, many of us received emails saying that the division of HIV prevention at CDC was going to be eliminated, right? And so there have been numerous actions happening across different organizations, policy and advocacy actions, contacting, you know, representatives and legislators, but also contacting health departments, contacting, other institutions to continue to carry the message of why HIV prevention dollars and EHE funding is so important. And so, eliminating this division also impacts 340B dollars, which many of our communities, particular communities of color who engage in HIV care and treatment, rely on to be able to provide services and more robust services for communities. And so I'm not sure if there's someone else who'd like to share about some of the changes. Yes.
Come to the mic.
Oh, okay.
Yeah, because they're not going to be able to hear you online. And they want to hear you.
Honey, they can hear me down the street.
I mean, I have to hear you, but
Hello, I am Denise Garrison. I work for Memphis Shelby County Schools. I work under a CDC grant that was granted for 5 years on what works with schools. HIV, STD, teen pregnancy is one of those components, and health education and sexual health services. With all that being said, every day we get a new email from Grant Solutions that tells us what we can or can't do each day. We are working to rewrite our application, and yesterday we were being told to make it very vague, not to include like the populations like we've done before, to just make it a whole lot more about this is a reimbursement for what works in schools, or this is to help our high schools. It's got to be very generic for now, just to keep the funding going. It's not that we're pushing away from our work, because my legal department has told me we don't have to push away from our work, but it's to not trigger anything on the federal standpoint for our funding. So it's just being more creative of how we write and how we do things. Like yesterday we talked about, if you're doing free testing, you can always say you're doing free blood pressures, and they get in there, you do have free testing, but you get them in the door. And so it's mainly trying to recreate what we're already doing, but in a more friendlier, I guess, or dummy downed. But we're doing it to protect our funding so that we can keep doing what we've been doing.
Thank you so much. And I also saw we have one more hand in the back. Did you want to come up here and share some of your experiences?
And while Austin joins us at the mic, I think it's an important note about the changing language that we're seeing in organizations, and how we are trying to be innovative in a very restrictive space, right?
Austin Carroll from Friends for All. We lost our short-term housing grant, like instantly, I guess about a month ago. And our housing department was able to get everybody rehoused within 24 hours. So that was really awesome. They've got a really good team, but there was also, we've had to, we've kind of scrubbed our website of pictures, and tried to change language. And I know that there has been, some controversy around a lot of places doing that. But what our executive director said, which I totally agree with, is that it's way more important for us to be able to serve the people that we do and keep the programs that we have going, than it is, to publicly have everything on display. So I know that there's had to be a lot of change in wording, just like you were saying, but I also think that that it's important for all of us to give each other grace during these times as we all try to figure out how to navigate this crazy landscape. So that's all I wanted to say.
Thank you.
Thanks. And I think that's an important note about, the importance of, many of us are organizations, the objective is survival, right? In making sure that we survive and protect as many of our programs and people as possible. And so that does take a level of collusion with community, right? Because there does need to be a basis of trust where we're eliminating things from online, from maybe more public areas, but that doesn't mean that we've stopped serving folks. And so we'll talk a little bit about what that collusion can also look like.
Yeah. So, hi, everybody. I'm from Latino Memphis. We're funded through United Way of Greater Nashville through the CDC as well. So we received a lot of that guidance as well to kind of adjust your language. I think we're in a particular fun situation where the people we're served is in our name. So it's kind of hard to adjust to that. But also another thing that we've done at the programmatic level is kind of be careful on how we're advertising and reaching our folks, especially since we work with a lot of undocumented immigrants, and we don't want to be targeted for that either. So we've been kind of trying to find the line between letting people know we're here for them and we're here to serve them, and also, but also not making ourselves a target with all of the immigration stuff that's going on. What we've done is we've kind of pulled back from doing ads on our social medias, which is what we would traditionally do. We've moved to increase our efforts in text messaging, so people can. We have around 9,000 contacts around on that. So kind of investing more in that as a resource to reach our community. And then when we're doing events, we're doing it in our office now, which isn't ideal. If anybody's been to Latino Memphis, it's a little small, but that way we can protect our community as best as possible. Like, we lock the doors at all times. It's a little tedious, but we're opening and closing, locking it up, because we want to make sure that our community feels safe coming to us, that at least Latino Memphis is a safe space for them, where we know something like, your documentation status is something that's looming over you, but at least we're trying our best to keep you safe. So.
Yes.
All right. And I also want to thank you so much, Estela. And I think that as we talk about how we protect folks, we can also consider, right, the spaces that we're in and how we can best support each other. Does anyone over the Zoom virtually want to share anything? And I'll be honest,
We can see the chat on the screen.
Oh, perfect. Okay. I'm like, I can't see it here. Yeah, and you can come off mute if that's easier, but if not, it's okay. We can move on.
Yeah, let's move on.
Okay. All right. So I'm going to start by sharing that that accelerated deportations are a contradiction to our public health values, right? What we have been seeing goes against the principles under which we work, which is equity, right? Value of every life, and the idea that we're here to prevent harm, right, in community. And so part of that is understanding that people who come to the US come to improve their lives. And often it is a response to physical violence. It's a response to sexual violence. It's a response to climate change. It's a response to oppression and poverty. But it's also a response to the destabilization that often the US causes in our home countries, right? And so many of us, at one time during this, with everything happening, may have joked like, oh, I need to move out of the US. Things are getting wild here. And the difference here is that there are people who do move for safety. They do move because of the destabilization. And this had not happened. I want to say that often I hear, we've been here before. And I just want to reaffirm that we have in fact not been here before. The first administration looked very different from what this administration looks like. And I'll point out a few changes, right? But I think it's important to reflect that this is not this is unprecedented, what is happening, right? Having conversations about eliminating a division, the elimination of departments, the risk of losing Medicaid, these are not conversations that we had before in this manner, right? So I want to reaffirm that we have not been in this space, that this is new. and that we don't have experience being resilient in this way. So I want to start off by sharing some of those points because I think it's important that we frame these conversations in that way and honor that the fear that many of our communities face, many folks who receive Medicaid, Medicare, Social Security, veterans, right? Folks are having difficult conversations about how they may need to cover medications, care, and treatment in the future. So I also want to share that the fear of deportation also makes communities less healthy, right? And so if you have a fear of driving, afraid of using public services, if you're scared of getting involved in your community because of what is happening, and this fear is substantiated, right? Immigrants are changing their health-seeking behaviors for themselves and their family members because they have a fear of being stopped by police or ICE for potential deportations. And what is new this time around, right, is that they're not just going after folks who are undocumented, and they have detained and arrested US citizens, green card holders, refugees, asylum seekers who had a legal status, folks with DACA and temporary protected status. So this is where we're getting into new territory where there's a normalization of what detention and deportation proceedings is happening. And now folks are being deported to other countries, right, without due process. We're seeing movements around children having to have court dates with no attorneys or guardians present. So these are all things that are happening. And some of that is not new, but at the level and scale that we're at is, right? We also know that immigrants will miss medical appointments, right? And so they're less likely to use health clinics, to have regular doctor visits, to receive diabetes education, to receive prenatal care, HIV prevention, HIV treatment, vaccinations, and folks are not getting the medication that they need.
Mm-hmm.
If folks are afraid to drive, they're also less likely to access healthy foods, right? Because many of our communities live in food deserts or food swamps. And so folks may not have access to grocery stores to have fresh produce, and it's also a deterrent that is impacting their health. And this is similar with accessing public spaces, right? And we see some similarities with trans and non-binary communities where they're also being excluded from public spaces like restrooms and, sports. Some of these things, it's the same thing. It's about having access to these spaces. Mm-hmm.
And then I also wanted to just briefly add, aside from the actual physical health issues that this brings up, we also have to take into consideration the mental effect, right? The anxiety, the depression, right? As a mixed status household, for those of you guys who don't know, what that means is that in my household, we have people that were born in the U.S., we have people that have green cards, and we have people that are undocumented. And so for us, there's a chance that, when a family member goes out to work, they may or may not come back. In Memphis and a lot of parts in the country, there's been immigration, ICE patrols doing raids. And so this also affects the mental health of the communities, right? Of constantly being in fear, of having that anxiety, aside from what Judith just mentioned. Thank you.
Yeah, and we've seen stories, right, of little kids committing suicide because they're getting bullied, and fear that, kids are saying, we're going to report your parents for being undocumented, right? So these are all things that we'll continue to discuss. So I often like to talk about this like a storm, right? So in the South, we are used to hurricanes. We're used to tropical storms, tornadoes, all these types of storms. Just with good food comes bad weather, right? And so we know that sometimes there's like a tropical storm, a thunderstorm, but I just want to say that we are in like a category 5, and it is going to hit land soon, if not in some parts already. And so some of the storm that has been building is some of the reversal of policies that exist. And we see that protected zones are no longer they're no longer protected from ICE presence. And so that included churches, schools, and hospitals. So we saw that directive that the Department of Homeland Security and Immigration and Customs Enforcement can come into these spaces now. That's different from the first administration, right? They did not go into schools, churches, and hospitals. And we also saw a growing movement of the sanctuary church movement where folks were finding refuge in churches. So these all stem back to abolition, right? And those practices of protecting community. And we also see cities, passing ordinances around sanctuary cities, right? And saying we're not going to allow law enforcement to work with immigration and customs enforcement. So these are all things that is being threatened now. There's also a lot of disinformation that fuels stigma regarding HIV and immigrants. And during the presidential election, we had the candidate for vice president who was mentioning, Haitians and HIV, right? That Haitians were bringing HIV into this country and just saying a lot of disparaging things about Haitians. And the HIV movement owes a lot to Haitian communities for all of that stigma. So when we talk about immigrants, right, we're not just talking about immigrants from Latino countries. Like a lot of folks are being impacted, and actually Black immigrants are detained at much higher rates and deported, right? And so that's also a conversation we don't talk about enough. But this disinformation that occurs is also part of a strategic move, right? And I'm saying disinformation because there's a difference between dis and misinformation, right? So misinformation is when you mistakenly share information that is incorrect, right? Like maybe you said, oh, the Latino Commission on AIDS, that's a faith-based organization because we have a faith-based program. However, we're not a faith-based organization. Not that there's anything, wrong with that, but we're a community-based. So that's misinformation, right? It's not that harmful. Disinformation is when you're straight up lying, right? Like, you're lying. And that's what J.D. Vance was doing, because he came out and said, I thought you weren't going to fact check me. So he knows, right? And then some of this, disinformation also fuels discriminatory and anti-immigrant legislation in our states. And we've seen more states engage in immigration legislation that is xenophobic, right? And so we have policy changes at state levels where, for example, in North Carolina, they passed a law stating that only citizens could vote in the election. Now, why would they need to pass that law if it's already a law? Right? It's just fueling the disinformation that non-citizens vote in elections. That people were that's why Trump lost, because there was a bunch of people who voted, and that's just not true, right? So now you have states spending time on these types of legislation. We also see the removal of LGBTQ and HIV information on official government websites. This also includes websites on maternal health care, like it's expansive how much information was removed. And while there is an order to return some of the pages, we still see directives to changing the language, right? We can't have DEI language. One university was trying to take out the term culture. Like culture was now a term we can't use anymore. And the information is no longer available in Spanish. English is now also the official language of the US. But I think we fail to, well, not we, but folks fail to understand that there is a territory, Puerto Rico, where they speak predominantly Spanish and they require information also, right? Because they are part of the US. And I have some resources about what this means for providers. So I'll have a resource sheet for you all with some of these tools.
And then to give some examples on what's going on in our state in Tennessee, right? So just last month we had a rally around Memphis immigration, and in that rally they made some demands of some of the injustices that are going on. So, for example, in the rally we were demanding to reject HB 0793 and SB 0836, saying that no child should be denied public education based on immigration status. So the mere fact that our government is trying to take away education, which should be a right for everyone, regardless of your immigration status. Also, we demanded to oppose HB 145 and SB 268 and stop discrimination in schools, stop tuition fees and citizenship checks for immigrant families, stating that if you or if you're a child of immigrants, you're supposed to pay for this education that's already being paid by our tax dollars that everyone pays, regardless, again, of your status. And then also with Sheriff Boner publicly opposing Shelby County participant in the 28-7G, we demand transparency and end the local collaboration with ICE, right? So kind of like Judith was saying, some of these storms have already hit the ground. Some of them are about to hit other areas. But these are things that are occurring. You know, this was just last month. So I did want to kind of just highlight some of the things that are occurring in our own state. Thank you.
Thanks, Jessie. And so some of the removal of information is also a way to continue to perpetuate disinformation, right? Because now we don't have the guidance is already provided. We don't have the data available to share what is truly happening in community. So when we think about, for example, these 287G contracts where law enforcement will be required to work with immigration and customs enforcement, there's so much data stating that that does not make community safer, right? There's a lot of data sharing that in actuality, it makes folks less likely to call law enforcement for help in domestic violence, in emergencies. It makes it harder for law enforcement to gain trust in communities because there is a fear of like, who are you? And what are you doing here? And why are you patrolling? And so there's extensive information that actually there is a reduction in crime when we don't have these factors of militarizing or deputizing law enforcement, right? Yes.
I just wanted to add too that a lot of times in the news, I don't know if it's for everybody else, I look at it. A lot of times in the news, it's whatever's going on in that little area, they slide the other stuff under it, and we as a community don't really know that it's coming to face or that they're fixing to vote on it because we're watching this big breaking story. And so we're watching this bill. So a lot of times those bills are missed, at least by me, because I'm watching the big story.
Right.
And so, you know, making sure it's coalition and everything, that watching those, I was like, wait, what?
Mhm.
You know? And so, again, when the big stories break, we're all jumping on them. But the little stories or the other pieces of the puzzle, what I like to call it, slide under it and nobody knows until it's done.
So I want to share for folks on Zoom that a comment made in which often when you're following news stories or media, that they'll share like a really big story, and legislators will, introduce like a big bill that may be more controversial, and you're following that. But because of that, all we're missing some of the other legislation that they're sliding through, right? And so as a coalition, it's important to look at some of these pieces that are being added. Mhm. And I think we'll also talk about some of those strategies as we respond. Hold on. I'm on like a different screen. Okay. All right. So I wanted to talk specifically about one executive order that is called the Targeting Immigrants and Federal Assistance. And I'm hoping that you all connect the dots here. But the executive order was called Ending Taxpayer Subsidization of Open Borders. And it essentially did 5 things. It directed to identify programs that allow immigrants to obtain public benefits. The federal payment to states and localities may be in jeopardy, or they're asking not to support non-citizens or sanctuary city policies. And there needed to be a eligibility verification enhancement for systems like Medicaid, SNAP, to ensure that there's an exclusion of non-citizens. And they should be reporting or referring the use of federal benefits to the Department of Justice or Homeland Security. So from these 5 things, does anybody know what program may be impacted? There's one very big, it's not listed here. No. It's Ryan White. It's not on the sheet. Yeah. So non-citizen immigrants are largely ineligible for federal public benefits like housing programs, nutrition, healthcare, right? There are some limited exceptions, which include emergency Medicaid through MLATA, right? So labor and delivery, or like in moments where someone really needs care, they'll go to the hospital and they're connected with like a caseworker, and then they're eligible for emergency Medicaid. But even green card holders face a 5-year ban from being able to access Medicaid. So there's already systems in place because there's something called public charge, right? And public charge is this ruling that says that non-citizens who are applying to become U.S. residents or U.S. citizens need to prove that they will not be a burden on the government, right? Like they're not going to give citizenship to someone or residency that's going to need long-term care that needs to be provided by the government. So these are already things in place. However,
Just in case everybody, I mean, I don't want to speak for everybody in the room, but can you elaborate?
yeah.
I was just going to ask if Judith could elaborate on what Ryan White is, just in case not everybody is aware of what that is.
Oh, okay. So historically, MLATA, like Emergency Medicaid, and Ryan White, which is a federal program that allows people living with HIV to access care and treatment. And it does not have requirements on legal status. So folks who are non-citizens are eligible for the program because it's a public health measure, right? And our ADAP program, our AIDS Drug Assistance Program, is part of Ryan White. You know, a lot of the dollars that folks get to provide services are through Ryan White. And but historically, public charge did not include Ryan White and MLATA. And when there is a budget, usually programs have to go through reauthorization. And so for several years, Ryan White has not been reauthorized or reallocated funds to, or like had an analysis to allocate funds to. They've just requested for the program to keep going because they were like, this political climate isn't one where a reauthorization would be beneficial to people living with HIV. And we also didn't want them to know that non-citizens were using the program, right? So it was a collusion, right? There was some trust here in how advocates were working towards this. That with this executive order and analysis, it is very likely that the Ryan White will change who becomes eligible if Ryan White even exists.
That part.
Right? So we're seeing cuts to Medicaid, almost like erasing. So if we believe that they will erase Medicaid, that they can, why would they save Ryan White, right? So the way people get treatment and get treatment paid for. So this is important in the way that we think of our work and our HIV work and how we are going to restructure and respond, right? All right, so let's talk about, does anybody have any questions about these pieces? I can't see it. Okay. Okay.
I'm on the train, so I'll ping you on if I see.
Pardon?
Sure,
you're
let us know,
okay.
yeah.
Good. Okay. So let's talk about preparedness, right? So whenever you're preparing for a storm, like there's still time to go get eggs and bread. We're still at a good moment for that. And what that looks like for our organizations is, and actually, how many of you are healthcare providers, if you can, or work for a healthcare providing? Okay. And then how many of you all work for a community-based organization? How many of you are community advocates? Oh yeah, if you can drop in the chat. You don't have to list like what agency it is. But that way we can get a sense of who's in the room. Did I miss any sector? Oh, a federally qualified providers. Federally qualified health centers. Oh, we have a research nurse. So we have to, part of being prepared is understanding who is impacted. And that has to start with our staff, right? We come first. That's in my program, I'm like, as staff, we have to come first because we have to be well. We have to know what's going on. So understanding who may be most impacted by these executive orders, these changes in policies is important. So for example, in our program, I know who has DACA, who is, a non-citizen. And notice I'm using the term non-citizen, right? I'm not necessarily saying someone's undocumented. They're just not US citizens. Because in this case, it really doesn't matter, right? Everyone apparently is at risk, even US citizens in some cases. Somebody was just detained for a couple of hours and they were a US citizen. They were carrying their social security. Law enforcement never, or Immigration and Customs Enforcement didn't even try to look at their information. So understanding who's being impacted by all of this so that folks can prepare their organizations and prepare with each other, right? So this is about being in community. And then also understanding who are our clients, who are the patients, who's most at risk here for losing care, and how are we going to strategize? But first, it's about identifying folks. And I'm not saying make a list with names and addresses and say, like, this person has DACA, you know. This is about, like, just understanding who's in community with you. And then also determining what internal and external procedures staff training is needed, right? So what changes do we need to make? That may be in terms of physical space. We had Estela share that they're locking the door. You know, they're now meeting in their office. And so what kind of procedures do you implement in your organization? And as you're doing this, it's also important to start mapping out resources and identifying gaps, right? Okay. And now there is time still to do some rapid response, right? Many of our organizations are shifting. They're shifting language. They're shifting, you know, the way we're talking about things, where we're putting things. And so it's important to think about some of this as strategic planning, right? And so creating a response team has worked at our agency. We created a response team through our management team and some others to evaluate policies and to look at what's happening so that we can shift things more quickly and sort of share the information we're receiving. It's also important to look at the fact that some of our organizations are in moments of crises. It is natural for people to go into a fight, flight, or freeze response. And we know that some of us are in freeze mode right now, right? Like, we're like, let's just wait and see what happens. Let's just keep waiting. Let's wait and see. Things are changing every day. There's no point in making any changes right now because things are changing. It's getting worse. Let's just, you know, not do anything. And I want to say that creates more anxiety within staff, within clients, and in terms of the structure, it's not going to continue to be sound to just wait. So I want to encourage folks. I'm not saying go out there and be in flight mode or fight, but I am saying let's get into a strategic mode of making plans. And that also includes, you know, resourcing some advocacy and legal efforts to combat some of these harmful policies and protect communities. So that means we cannot be preemptively complying, right, with some of these executive orders. We saw this in Illinois, where when there was a change in, it wasn't an executive order, it was, something else happened. It was like January 26th, I remember, that they said, oh, we're going to stop funding. We're going to stop paying grant funds. That's what happened. And the state of Illinois said, okay, we're stopping Medicaid today, because they have a trigger law in Illinois where if they don't receive a certain percentage from the federal government, their Medicaid program stops. So they did. And that may have been malicious compliance by saying, like, oh, bet, right? That's what my nephew says. He's like, bet. And they were like, oh, we'll see what happens when we stop Medicaid in an hour, the chaos it creates, so that people respond. But that needs to have like a real coordinated response there about it. And then, but there are also people who decided to like definitely start stopping some program, like, oh, we're gonna start letting go of staff. It was not the time, right? Like, we didn't know what the legal implications were. We didn't even know if it was legal, and it was not, right? Like, this is not how things should happen. So we also need to understand what directives are legal and what are not. We saw this also with housing programs, right? When they were like, we're going to stop the funding, a lot of housing programs were like, well, what are we going to do? How are we going to? It's so close to the first of the month. We need to pay people's rents. There, in past, if there was a delay in payment, some of these housing organizations were like, we can take out a loan because we know we're going to get the money. But in this instance, like, they were like, we can't promise this anymore. And there also needs to be some flexibility in the response, right? Because things are going to continue to shift and change. And we also need to advocate to fund emergency health services and some of this outreach in these times as part of this rapid response, right? And so, okay. So what are some response strategies that we can engage in? When I wrote this out, I was like, collect data, don't collect data. And we need to collect data because we need to know who is losing care and what type of care they're losing. We need to know who's not returning to care, not because they've lost care, but because they are scared to come in. We need to collect demographic data, even though we're not being required to or encouraged or paid to. We still need to know who we're serving. And we need to be collecting data around funding and programmatic changes, right? So if before we were serving men who have sex with men in Shelby County, is it now we're serving like low-income uninsured men, right? And then I'm also saying don't collect data. So don't collect certain data. And if you are, you have to protect that data. And that is a response that your team needs to look at as to where this data is being stored. And this can be data that is like, well, yes, we do know where, we used to know where trans individuals live. Like these are our clients. We have 12. These are their addresses, but maybe you code them differently. Maybe now it's you have them listed as a number, and that number takes you to a different place where there is where you have the information that you need. So it's about being strategic in this way and protecting sensitive data. We're going to add about what you all were doing. Okay. Well, Jessie told me a story that I tried to remind him of, where he was saying that at his former organization, they would have to enter in data.
Yes, okay. Sorry. Yes. So this is way back when I used to do prep and HIV navigation, right? Entering information to RedCap, for those of you guys who are familiar with RedCap, right? At that time when we were doing the entry, we worked a lot with the LGBT community. And when we were testing our trans siblings, it was really disheartening and frustrating having to go into these systems where it was only binary. It was male or female. And so it really took a lot of efforts from my team and a bunch of you guys here, from our colleagues, to have these conversations with people who were designing these data entry websites, to making sure that we had an option to truly reflect the community that we were serving. Because as we know, data is very important when it comes to funding, when it comes to research, right? So we wanted to make sure that we were representing our community in a very authentic way. However, now we're seeing the opposite, right? So we're seeing our efforts basically being pushed back to where now they're going back to only binary male and female, and they're not necessarily including information that we know is very pertinent to the work that we do, specifically in HIV. Thank you.
Great. I'm glad you remembered.
Took me a minute.
All right, so some of the other response strategies we can think of is like reimagining healthcare delivery strategies, right? And so we learned a lot from COVID-19 about what is possible and how states and cities and municipalities can move resources, right? And so that means that maybe there's coalitions being built with diverse populations and partners. A reintroduction to telehealth in some instances. So folks who are afraid to come to receive services or afraid to come into organizations now have that option. And that can also be like for some counseling or even creating like virtual meetup groups, you know, for community-based organizations. Like how can we reimagine what it means to be in community, thinking about COVID-19 and the strategies we implemented there. I think it also means restructuring some of the community engagement that we have. So if we have community in fear, like how do we leverage partnerships to with some of this limited funding, right? We have limited funding, limited resources, but folks need to hear about the services. We're not putting them on websites. So how are we engaging with community? How are we finding folks, right, that need these services? And that does require working across different partners, right? And so historically, like HIV work has been worked alongside a lot of LGBTQ communities, but not necessarily immigrant communities, not necessarily other communities that maybe in some instances faith-based communities, right? Like where folks are also receiving services. And during COVID-19, we saw a broader response where, yes, we were providing, there was an organization or church providing food, but we were also providing, you know, COVID-19 tests. And so how can we leverage what's already existing in these spaces? And then we also have the opportunity to build up some capacity in our organizations and train our staff around some of this. So that means that staff should know their rights, right? Like knowing their rights and how to create a safety plan at your organization. So if ICE does come to your church, to your hospital, to your healthcare provider, your FQHC, the health department, like what can you do? What rights do you have as an organization and as an institution to protect your staff and the people they're asking to get services, right? How far, like understanding that legal piece, because for example, there's an AIDS service organization in Alabama where when you walk in, there's a receptionist who has to buzz you in. They're like, oh, what are you here for, right? They have like a little window and they buzz you in because they have several like spaces to go into. If that person is not trained, right, and Immigration and Customs Enforcement comes and they're like, hi, I have a warrant for your coworker, right? They'll be like, oh, look, I have a warrant. And they're like, okay, I'll buzz you in. That warrant may not be valid, right? And now you are letting them enter space where they can see things, see names, see sensitive information that they shouldn't be seeing, that nobody should be seeing, right? These are protected spaces for a reason, right? Like, so this is where, you know, we have to think about all of these things in a safety plan, not just for, right, like, what do we do at the higher level, but also what do we do at first interactions? And maybe your front desk staff is like, hold on, let me go get someone else. I can't buzz you in yet. And like goes for help. Like, what does that plan look like? Who are they going to? Who can recognize this information? Who can be like, actually, no, you can't enter here. It's not a public space. Clearly, the doors are closed. Yes. Yes, it is a violation of HIPAA. But we also know that there have, when there was state legislation around trans healthcare, many hospitals turned over medical information. Do I have anybody from Vanderbilt here?
Vanderbilt.
Hospital, they turned over
Mhm.
the records of people receiving gender affirming care to the state. It is a violation, but why do you think they turned them in? Fear of losing funding? And maybe they were like, well, it came from the state. Like, I guess we have to comply. It's not having that strategy of like, what is the legal recourse here? Right?
Mhm.
So being able to sort that out before you put people's lives at risk, because that's what this is about, right? Is important. And so you can look up like what Vanderbilt did. And part of capacity building and staff training also means growing partnerships to help minimize some of the burnout, right? There's a lot going on, and we cannot do everything all the time. And so we have to make sure that our work is intersectional and effective. And that means working across partners and trusting that, like, we came up with a plan where, like, our program can't do this, this, and this anymore. We got to trust that someone else has got it.
Mhm.
And then maybe we talk to them and be like, listen, we're not going to be in these spaces anymore because we have to protect Medicaid. But if you got the housing piece, like, if you've got harm reduction, we'll show up when you need us to, but we're just not going to be in this space in the same way anymore. Not because we can't, like, we just don't have the capacity for our staff. So it's about making these strategic decisions. And maybe they'll say, well, great, because like we didn't have capacity to be in this space anymore either. So it's like these conversations where we know we're still supportive, we'll still refer, but like we also need to protect the mental space we have. And then one of the other strategies I wanted to share in terms of response is leaning into language justice, right? So here we have a sign. I wish I could move. We have a sign that that states that that was put up on a door. This is from a clinic in South Carolina, and it says, Hispanic patients. The free clinic does not have translators available. It is the responsibility of the patient who does not speak English to bring a translator. If you don't, you risk not being served. It is not the obligation of the clinic to provide a translator. Thank you for your cooperation. So what does this say to maybe some of the Hispanic patients or patients who do not speak English, but also don't speak Spanish, right? Like, what does this say to them? I didn't hear, sorry. You're not welcome. Yeah. We don't want to serve you because they're a free clinic. They're not required to serve you.
You're a burden.
It's a burden, right? To provide services. It's not a safe space. No. And, you know, who are you going to, like, if you didn't speak English, who would you bring to translate for you for maybe like a chlamydia appointment?
My child.
Not your child, right? Like, no, it does happen. Like, what I'm saying, I said chlamydia specific because I was hoping like you'd be like, oh, I don't know who I would try, but no, you said my child and it threw me off. So the comment is that someone worked translating, did medical translations and interpretation, and they weren't even allowed to have children be interpreters in that situation. Yeah, and then
So there was a comment in the chat, and it says in reality, for some folks, their children are the only translators they have.
that's correct. But in medical settings, if I need to get a pap smear, is my kid the most appropriate person for me to have translate around my sexual history, or so
Pretty
this is
invasive.
so it becomes very difficult for folks to find.
Someone.
And even if you found, let's say, a friend,
It's still
let's say you decided that you could translate for a coworker. Like, now you know their business, right?
Yep.
So it puts people in a difficult position.
And I will say, like, most of the time, if there's not a translator, I mean, we have Claudio, but if there's not one in that school, then there are children that will come up there and talk. And so, and there's a lot of children that go with their parents to the doctor, because when we did a pamphlet, we did Arabic and Spanish and English. And the Arabic children were so excited because their parents could actually read it. To know what the resources were, because their parents had no idea how to read it without, the Arabic language.
We had a comment that in school systems that a lot of children do come in to translate for their parents. And once information was translated into Spanish, Arabic, and English, that students who spoke Arabic with parents at home who spoke Arabic were really excited, because now their parents could read what was happening. As someone who has translated for my parents or interpreted for my parents, I also know that the information was not always accurate. And sometimes I lied. Yeah.
If you're not saying, if you're not like being accurate, I'm sorry, but I'm not allowing you to be the next one. Because I'm here, like, even though you say you did something for him, that's my job to be here. I'm supposed to be the one to information. Well, next time I'll have to.
So we had another comment where there was someone, a family member of a patient, who was not telling the patient that they had cancer. So now you're not disclosing accurate medical information. You're keeping folks from being able to make medical decisions for themselves, right? And then I know we had
Types of language things correctly, which I really like that. When I was reading, I was like, that is so true.
Yeah. So how can we lean into some language justice practices? And gracious. So here's another sign, right? And this is from a children's clinic. And it says, regardless of your immigration status, everyone is welcome at our clinic. So how could we improve this sign? Like, if you were to put up a sign, we know we're not putting up things on social media, on other places, and we're relying on physical spaces, right? For folks. Pardon? Everyone is welcome. What else could we say? Making a long list of everyone you serve. Yeah. Right.
And at the end, you say, this is not the complete list. Please seek services.
Yeah. So making sure that folks who maybe are non-binary or on forms that they're filling out, right? Like we're being not only affirming in the spaces that we're in, but also that we're having some of these signs up in our clinics, and that we're investing in that. Yes. I love that. So we had a comment where someone shared that they have a stylist, a hairstylist, who has a new motto where it's no one left behind. So even if you can't pay for services, they'll provide them, right? And I think that's a really beautiful way of communicating to folks that we see you, we value you, you're deserving. Yeah. So, yes. The World Sustainable Goal. Oh. Yeah. Right. Health in all places. Yes. Mm-hmm.
It's almost like the disinformation of HIV is what we know.
Yes.
It's so Eurocentric.
Yep.
It's actually wrong.
Mm-hmm.
And that we're now being challenged to really find the validity of our grassroots work by getting into what our community experience really looks like. That it's always been a disease predominantly in the uninsured and the poor. And that people with access to service shouldn't be writing the book. So when they write the rule, they don't write it. Their burden of equity doesn't meet all. And I've lived places like Seattle where I've seen white people work for the health department there. Martin Luther King face on everything. And I said, why y'all name our county after Martin Luther King? And displaced all the black people out of Seattle. So I saw then that white people want the dream of King, but they didn't want us in the dream. And so I also think that the Latinx community needs to partner better with other black and brown communities because our economics,
Yes.
and our way that we can work together in growing and become more sustainable will be a really great resource for one. We're already living with each other. And when we first started, I'm going to say this today. The fear slide hurt me because about last summer I saw this Latino kid kicking a ball through playing soccer across the street, just kicking the ball. And I called all my friends. I said, you see all the joy on that kid? I got black people that want to go outside, but now I can't see that kid no more. I might not see that kid no more. It just broke my heart. The joy.
Yeah. Thank you for sharing that. And I think when we think about this work, I think there is an opportunity. Mm-hmm. Mm-hmm. They did. They gave us 900 pages of what they were going to do. We just didn't expect it in the first week, right? Like,
yeah, that part.
We knew it was coming, just like, and we thought more people would stop it. So, okay. So let me see. I only have like two or three more slides. So I'll say that in leaning into language justice, it's important to publicly state your commitment to community. We are experiencing high levels of mistrust of institutions. There is a lot of folks who are naive in thinking that what is happening is going to improve things. But what we have is a lot of unexperienced individuals coming in and making cuts and firing folks who had a lot of knowledge about how things worked. And so, how do we lean into some of this transparency? How do we share more information? So, we're going to have campaigns against vaccinations, against immunizations. So, what do we need to be doing for that? Do I want to drink raw milk? No. Do I want to drink raw water? Also, no. Right? So, how are we encouraging folks to be like, you do need fluoride? It's not doing what they say it's doing, right? And then, but coming from a place of understanding that folks were lied to, and it was this big effort. I mean, I showed you like how they're changing websites, they're changing language, the manipulation of information. So often we look at folks who don't have the information as folks who were we look down on folks, right? But there's a lot that happened to get folks there. There's a lot of lies. Like when I talk to my dad, I'm like, Dad, let's get it together. I have to make sure I know what he's watching. He's started to watch The View, and that has helped because he likes Whoopi Goldberg. So it's helping, but like there's some serious monitoring that needs to happen. And then, also recognizing the root causes of migration, why people come, why people leave from a transnational perspective, right? What's happening in our home countries that have led Venezuelans and Cubans to overcorrect in this way? Yes. Mm-hmm. I love a historical moment. Mm-hmm. Yeah. It doesn't.
I've lived in white neighborhoods where I stopped believing in racism. I saw white people didn't like each other. I saw it wasn't a white thing. I saw it was class.
Yes.
I saw that all the white people get along in. So down here it makes it seem like no, they don't like each other either. And they don't treat their children right. But we learn to treat our children like them. But black women, their breasts in their mouth and fed, they're liberated.
Mm-hmm.
So I understand where we are, like the migration pattern. We don't see the cause and effect of how people got here. People enjoy the privileges, and you have Latino people saying, "Well, I don't like those kind of Latinos and these kind."
Yes.
And the unification will be so hard, even with the Latino Chamber of Commerce. The economic value of us merging into whiteness is the capital that we're fighting.
Mm-hmm.
What this does do is say if we can capitalize ourselves between black people and Latino people, we got two nations. And most of your black people are First Nation. So you got black, indigenous, First Nation blacks. Like me, I just found I had 300 families do all this status card. 2 weeks from now, I go to Canada to put my application. So then who am I really representing? We've always been BIPOC, black, indigenous, and we had all three of them on our birth certificate. We've been people of color, we've been black. So we all there.
Mm-hmm.
But we don't have a space. And I own 11 acres. So I have a reservation. So now we're talking about sanctuary law. Well, if you have a reservation, we don't talk the same because we're government to government.
Yeah.
And so I think that this is where Mexican, Latinos combine their communities with other melanated groups to capitalize on our health, having our own hospitals, our own clinics, having our own everything that's funded through our own capital. Because we have the assets. We have it. It's just that we've been going to them to get it through their way because their way seems. But one thing about tribal rights, a little bit different for all the grants, is that it's not what you said earlier. But really, the government listens to the tribe.
Not anymore.
Oh, I know, with the OMB stuff.
Yeah. And they're trying to end or violate some of the treaty agreements. So that's why I said at the beginning, what we thought is not what it is anymore.
Right. See, what they're doing also
Mhm.
changing it's a valuable identity.
Yes.
So your valuable
Yeah.
identity is no longer your American citizenship. It's a digital identity.
Well, they've been detaining
Right.
Native Americans.
I heard. That's why they sent an email the other day and told all the Native Americans trying to start wearing their outfits. Because they told them 2 months ago to start doing it, and then like last month they told them don't do it because they said we were telling them to start doing it because people were stigmatized. So we said representation would help change the culture. Now they're telling them, don't wear your feather, don't wear your hat, don't wear. I was like, whoa, because it's the look.
Yes.
So the look of Mexican, the look of Latino, the look of First Nation, you look all the same.
Mm-hmm.
Correct.
Yes. Mm-hmm. So just to wrap up, because we're over time, and we'll be around to continue to chat, but I think some legal protections folks can engage in is knowing your rights as an organization. The Center for HIV Law Policy did a really great webinar on what HIPAA is for organizations and how they can protect client data and what it means when you do get an order, because folks were just turning over things and information, and that's so problematic and difficult. So we want to encourage that staff know their rights, they know their healthcare rights, right, and have this information. And then this is also an opportunity because after a storm passes, there is recovery and rebuilding, right? And so we know that some of the institutions that were working actually weren't really working that well anyway, not for our communities, right? And so we do need to address the destabilization in community, right? There's going to be a lot of mental health care needs, a lot of mistrust in institutions, a lot of need for support, right? And then we also need to create systems where this shouldn't be reversed this easily, right? The advancements that we've made, the investments that we've made shouldn't be able to be reversed the way it has been. And then we can also take this moment to rebuild a different type of social and healthcare infrastructure. So there is an opportunity where now we're not just talking about, men who have sex with men in this zip code. We're talking about poverty. We're talking about poor people. We're talking about people who are uninsured, rural folks, right? Like these are conversations that I think the HIV movement can be having about how we restructure services and care to folks. And then finally, since we're at time, I do have a resource guide that I created for y'all. It has resources on language justice, on protecting your organization. It also has resources for community. So it has several different guides for different types of institutions. If you're a college campus, if you are a hospital, if you are a nonprofit, what sorts of things you should consider in some of this planning. And then our information is there and the slides will be available. Yeah.
We'll make sure all of these resources are shared to our audience and making sure that everything is collected and sent off for anybody who may have missed and wasn't able to join or anything like that. I did see a hand, but I want to make sure that I can't see what Jamie said. Thank you. Okay. Jamie said, thank you. It was a great session. Yes, thank you so much. Thank you everybody online. Thank you those that are in person. It does not look like there's anybody booked after us. So if you have any struggling questions for Jessie and Judith, please feel free to approach them. But without further ado, I will say thank you online people, and we'll go ahead and disconnect. And if y'all have questions for our presenters as well, please feel free to email them at the